Hello and welcome to the Parkinson's Foundation Wellness Wednesday webinar. Today we return to our palliative care series where we will share things to know about hospice care for people with PD. I'm Krista Ellis, Community Engagement Manager for the Parkinson's Foundation. Helping me behind the scenes are my colleagues Jenny Fearday and Laura Cameron. We'd love to know more about our audience, so please share in the chat where you're joining us from today and say hello to your Parkinson's community. I'm joining you from Western North Carolina. We are recording today's presentation. You will receive a follow-up email from us with a link to today's recording and other resources in the coming days. Before we begin the formal webinar, I would like to share a little bit about the Parkinson's Foundation. The mission of the foundation is to make the lives better for people with Parkinson's. Whether you are living with Parkinson's, caring for someone with Parkinson's, or working to end the disease, we are here to support you. To achieve our mission, we pursue three goals: improve care for everyone with Parkinson's, advance research toward a cure, and empower and educate our global Parkinson's community. Today's program is a great example of one of the things we are doing to help us meet these goals. The Parkinson's Foundation provides weekly educational and wellness programs virtually through our PD Health at Home series, including Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. You can learn more and register for these programs by visiting parkinson.org/pdhealth. Last month, we kicked off part one of a 4-part webinar series for our veterans living with Parkinson's disease. We will continue this series on August 31st with a focus on mood changes. You can learn more about these events and register to attend at parkinson.org/veterans. We would like to take this moment to thank PCORI, a patient-centered outcomes research institute, for their implementation award to support our palliative care series. Thank you, PCORI. Today's PD Health at Home is presented by the Light of Day Foundation. We want to take this moment to thank the Light of Day Foundation for supporting the mission of the Parkinson's Foundation. As we close announcements, we settle in to explore helpful tips to prepare for our future and to support our decision-making related to medical care and treatment. During this session, we will cover important questions to ask your medical team and family members about goals of care and planning for the future. Following the conversation, we will have a live Q&A session. Thank you for joining us today, and I'll see you after the video.
This is a series of videos for patients and care partners talking about advanced care planning. In this first video, we'll introduce some of those concepts. Hi, I'm Andrew Huang, and I am a fellow here at the University of Rochester in palliative care.
My name is Tom Carroll. I'm here in Rochester, New York at the University of Rochester, where I practice general internal medicine, so primary care for adults, and also palliative care for adults. And I do those things both in the hospital and in the office.
So I know there's like a lot of terms sometimes we use with advanced directives, advanced care planning, and goals of care. And, I was wondering if you could just frame how you think about all these concepts and how they might all fit together.
Yeah, absolutely. It's one of those things that these terms get used in different senses by different people at different times. And honestly, they become jargon in the medical world a lot of the time. Even to the point that sometimes in the medical world, I say one of these terms and somebody else in the medical world may not use the same definitions. So taking it with a grain of salt, because there could very well be disagreement, and that's okay. But just to kind of put it in a little bit of order for us, I would say that, if we think about goals of care, advanced care planning, advanced directives, and code status, I would put goals of care kind of at the top and all encompassing. That it really includes anything, things in the medical world and outside the medical world, right? Things that we want to accomplish in life. And those really are the goals of our medical care ultimately. If we take the next kind of step down, if you will, advanced care planning, I think is more kind of restricted to the medical world. And now we're thinking about in the future, what might I want under kind of specific circumstances maybe, or even just generally. And this might involve treatment, whether or not to go to the hospital to try to get acute kind of new problems fixed or whatever it might be. And then advanced directives is even more specific kind of thing. And this really comes down to those documents, those forms, which we're going to talk about: the healthcare proxy, the living will, these MOLST or POLST forms. And really that's the answers the question of how can I let other people know what I do and don't want if there comes a time when I can't speak for myself. And then finally, this like the smallest kind of category is code status, and yet it's one that probably takes up a whole lot more time in some sense than maybe it should, but at the same time, it's important. And that's really the question: if my heart stops pumping blood, what should we do, right? And that's really the specific question about this quote unquote code status. Sometimes people say, DNR, do not resuscitate. We'll talk again in more detail about that. But it's that really specific thing. And I'll just say it now, and I'll probably say it again, that when someone says something like, do not resuscitate, like don't start my heart, don't try to restart my heart again if it were to stop, that should affect nothing else in that person's medical care except if their heart stops pumping blood, right? It's really important to say that really should not impact other things in the medical world and medical care for that person.
And who should be having these conversations? I know sometimes we choose not to talk about it. When is a good time?
Yeah, it's really, it depends on what's happening, of course, what sort of conversation we have, but it really should be everybody is responsible in some sense for having at least some of these conversations. And the details are going to be different, of course. If we're young and healthy, it might just be something as simple as making sure I know who the right person is to make medical decisions for me if, God forbid, something happens like a car accident, right? I'm unconscious even for a short period of time, perhaps. And then if I'm much, much sicker towards the end of some sort of disease process, then I'm going to be able to be more specific, and it'll be important that I be more specific. And so I should be having these conversations if I'm the person who's ill, or if I'm the family member of someone who's ill, or if I'm the clinician, the doctor, the nurse, whatever it might be, taking care of somebody. So really, everybody should be having the conversations one way or the other.
And, I know instead of just talking about the code status, getting at goals of care is, much more important, but it seems sometimes hard to really get at that. And it can feel so broad sometimes. When you talk about it, are there certain types or specific goals that come up a lot?
Yeah, the probably the first thing everybody wants to know is, can you cure this thing, whatever this thing might be, whatever the disease is? And if the answer is yes, that's great. Of course, then there are many questions within that, like what's going to look like to cure it, right? Oftentimes there's a lot that needs to happen. If someone is diagnosed with something that's not curable, there's still many important things to talk about, of course, including what time means to that person and how much of it there might be, what the quality of that time might be, and that quality thing becomes a jargon term that we have to be careful about. Patients, people thinking about function, what physically can I do? How can loved ones support me, and how can I support them in return? And how can they be supported by the medical team, and how can we all work together? Oftentimes people think about symptoms and the suffering that might come from those and how we're going to manage those kind of things. And then other really important things are like accomplishing goals, whether there's some sort of milestone in life or trying to, see somebody's graduation or wedding or whatever it might be. And then finally, last but certainly not least, is that idea of really, when someone does have something that is perhaps not curable or potentially not, the bigger questions of making peace with family, friends, making peace with God, whatever that might look like for that person. So really, it's very, very broad in terms of what should be included in there.
Yeah, it seems like such a hard thing to talk about sometimes and can bring a lot of fear. And, I think sometimes I feel like when we've talked about it, it feels like we're done, or if we talk about it once, sometimes you feel like we can be done so quickly. And I guess I'm just curious how you approach it, because it certainly is not a one-time thing. And talking about it can be so challenging, but so important.
Yeah, it does. It feels really hard. And the fact is it is, right? And it's hard, and it's also very important. So it's important that we do it. But what is it, right? What is this thing? I think one of the things that contributes to how hard it feels sometimes is that we almost feel like we have to do it all and do it right, whatever that means, whatever right looks like. But as you say, it's not a one-time task, right? It's not a one-time thing. And so I think that can sometimes take the pressure off us a little bit to say, I'm going to have part of this conversation, or at least get it started, and then kind of see how it goes and figure out what to do next. Recognizing at least two things. Number one is that it's not the only time we should talk about this, so we don't have to put that pressure on ourselves. And number two is that there's not necessarily one perfect right answer. It could be that there are a variety of things that could be the right things for me. And there might be a few things that are truly the wrong things for me. It's important to identify those and then avoid them, of course, if we can. But it is really important to recognize that it's not the one-time task. So we can take it in small steps as time goes on. And one other really important thing, we've all heard the phrase, oh, somebody says something that's a little concerning potentially about the future, and people knock on wood, right? It's almost this funny superstition that we all have. And I'm just going to say it because it sounds funny to say it, but it's true that talking about these things does not make it more likely that they will happen, right? Just to sort of put that out there, because we know that intellectually, and at the same time, we all have this, I think, internal fear that if I say it, it will sort of bring it to be. And then finally, just that it's kind of everybody's job to some extent. So again, we don't have to put all the pressure on ourselves or all the pressure on our doctors. We can kind of all share this task together and really work together to make sure that as time goes on, we just respond to whatever it is that might come up.
The first time I ever heard somebody on the palliative care team talk about what all the choices mean, it was from a medical standpoint, and lawyers don't tell you that. People will say, oh, I've gone to my lawyer, we've got it all taken care of. I said, you need to talk to somebody medical, because, and I've even had the nurse from the clinic here talk to my support group, and they were just blown away. They said, I had no idea it was, that's what those choices meant. So I think it's really important that they do that. And I think it's really important, like they say that they will do, is to take a look at it. Okay, you made this choice when you were with me last year. Have you thought about that? And are your choices any different given where you are now? So, and a lawyer is not going to do that for you either.
In this second video, we're going to talk a little bit about healthcare proxies and living wills. So there's so many different documents and a lot of different purposes, perhaps. I guess the first one is to talk a little bit about what the advance directives are. Dr. Carroll, can you talk a little bit about the different advance directives?
Yeah, absolutely. There are many different forums and websites and things out there. And really what it boils down to is that there are three main types of forms, and every state's going to be a little bit different. And so we're going to keep the discussion pretty general. We're here in New York State, but it's the forms tend to cover similar topics. They'll just look different, okay? So those three documents, the three primary documents, are the healthcare proxy, the living will, and then this medical or physician orders for life-sustaining treatment therapy, abbreviated either MOLST, M-O-L-S-T, or POLST, P-O-L-S-T, or some variation in your state.
And maybe let's just take one at a time and talk a little bit more about each.
Sure, absolutely. So the healthcare proxy, maybe to start with, will have different names in different states. Again, healthcare proxy is probably pretty common. The next, or another common one, is the durable power of attorney for healthcare decisions sometimes, or some variation on that. And really, no matter what it's called, this particular form boils down to naming a person who has the legal power to make decisions on behalf of you if, and only if, you lose the ability to make those decisions for yourself. And that loss of the ability to make decisions for yourself could be for just a short period of time, or it could be irreversible, depending on the situation. But as long as you're not able to make decisions for yourself, then this is the person you're telling the world that is the most trustworthy person and the best one to make decisions on your behalf.
Can the proxy always make decisions? Are there any exceptions sometimes?
Yeah, so that person, once you've made that positive step of naming that person and saying officially, this is the person I trust, they have almost as much power as you do to make medical decisions. The one kind of pretty clear exception to that, the one place where perhaps they will not have as much authority, has to do with this issue of artificial nutrition and hydration. So that's the feeding tubes and IV fluids. And the reason for that is that over the years, our United States court system, all the way up to the Supreme Court, has decided that that is a different kind of issue. Okay, that it's not just, it is a medical decision, but it's not just a medical decision. It's also about food, which feels a little different in some ways. And so through a series of court decisions, the courts have decided that there needs to be, and I quote, clear and convincing evidence. So it's this legal standard of clear and convincing evidence that this person knows my wishes in order for that person to make decisions specifically about artificial nutrition and hydration.
Well, I hope we all have proxies that know our wishes. What if someone doesn't know your wishes very well?
Yeah, and that's a tough one. And this sort of starts to transition into the idea of a living will versus a healthcare proxy. Because I should say everybody who's an adult should have a healthcare proxy. because even regardless of whether someone has Parkinson's or cancer or heart disease, whatever it might be, God forbid, there's still car accidents in this world, right? So truly, everyone should have a healthcare proxy. The question is, what do we tell that person, right? How do we have this conversation? We say, well, make sure your proxy knows your wishes. My response to that, I was always like, well, what do you mean? And it's really going to depend on who you are and where you are in your life. So the simplest, if you will, the simplest thing is to choose somebody who knows you and loves you, right? And would be able to, importantly, put aside their own wishes for you and be able to tell the medical world what it is that you would want rather than what it is they want for you. That's the basic thing. The more complicated things start to drift into this idea of living will, where we start to have this sort of if-then thing. Like, well, if this thing happens, then I do or don't want this other thing. We can talk a little bit more in detail about that too. But just to get a feel for the healthcare proxy, it's really someone who knows you well and you think could stand up for you and make decisions that, to the best of anybody's ability and knowledge, is what you would say in that same situation if you could.
So let's say if I'm a patient and I have Parkinson's and it is later in the disease course, then how does the living will come into play with this?
Yeah, so the living will has sort of evolved over time. Initially, it was created specifically to provide that clear and convincing evidence around feeding tubes and IV fluids that we talked about a moment ago. That was really the purpose for it initially. And it still is the purpose for it, still the primary purpose. What you'll find is that most states have this, if you will, boilerplate, right? These kind of check boxes that say, if I'm sick and everybody agrees I'm not going to get better, here are the things I do or don't want. And that can be useful and important. The one thing I just caution people about is being too quick to check off the I don't want things boxes. In part because a lot of times we don't know. If we're really sure and we do know, then it's totally appropriate to say, I don't want these things. To some extent, we have to just balance that, giving the proxy authority and kind of freedom to make various decisions versus restricting what they can say and do. I mean, again, that's going to be very person and time dependent, kind of depending on where you're at, who you are.
And it seems like there's different types of living wills with different groups. Can you speak a little bit to that?
Yeah, so there are those, every state has its own living will, to my knowledge anyway. The American Bar Association has a list, or links, I should say, to all of the state living wills. There are also some kind of interesting and useful living wills for some specific groups. And I'm sure that there are many more that I've found, but the kind of the three big ones, if you will, the three big religious groups would be the Catholic, Muslim, and Jewish living wills. Which again, one size doesn't fit all, and somebody who identifies within one of these groups, it may or may not be the right thing. But they're out there, and we'll provide those links too, because they are sort of interesting, and they can be helpful at the very least in terms of thinking through some of these questions with that sort of religious background in mind. And just, to keep in mind that there are the standard state living wills available as well.
It's so hard, right? I mean, the diseases can be so unpredictable, what's going to come in the future. It's hard to know what will happen.
It really is. Yeah, and so that's where we have to just really be thoughtful and make sure that we're being as specific as we should without kind of overdoing it and almost painting ourselves into a corner, if you will, by having things come up that we just could never have anticipated. And it's those unanticipated things that really is the reason that we have healthcare proxies.
And then lastly, in addition to the proxy and the will, it sounds like there's some online resources that might talk about this too.
Absolutely, and there are many, and again, many more than we'll list here, but we'll provide some links as well. Ariadne Labs has a very nice serious illness conversation tools for patients, in addition to for clinicians, right? There's also a group that does the Conversation Project. There's another that's Prepare for Your Care. There's another called 5 Wishes, and again, many more. And these are really valuable. Some of them are more involved than others. Some are, dozens of pages long and very, very detailed. Others are less so. And so you can find the one that works for you. The other thing to keep in mind is that these do provide some, certainly guidance and help us talk through these things in an organized way ahead of time with our family members, which is great. It's important to keep in mind that they're not oftentimes, generally speaking, unless they say otherwise, are not specifically legal documents. So if push were to come to shove and it was unclear what to do, or there were some disagreement among people who could potentially be a decision maker for a patient, they could provide some evidence in a legal sense, that you had done this thing. but they're not specifically legal documents. And so it's important to recognize that they're really helpful for guiding conversation down paths that are useful. And at the same time, generally speaking, do not take the place, certainly of a healthcare proxy form, and probably not the living will form.
In this third video, we're going to talk a little bit about code status, specifically with MOLST or POLST forms. So in the last video, we talked a little bit about proxies and wills, and now to this third form, which is this MOLST form. This is the pink form that everyone always talks about. Can you just frame that a little bit and what its purpose is for?
Yeah, absolutely. So really, this form is meant to tell us what to do in a moment of sort of extreme stress, medical emergency, and nobody in that moment could possibly make a good informed decision, right? And that specifically is when someone has no pulse. Okay, so that's the primary thing. If God forbid you find somebody down and they don't have a pulse, the default thing, we all kind of know this, is to do what? CPR, right? And because it's such an emergency, it's the one thing in the medical world that we don't have to get explicit informed consent in order to do, right? Otherwise, if you want whatever kind of treatment it is, you have to kind of sign an informed consent form, whatever it might be. But in this one, because of just the nature of the emergency, there's not time for that. And so in our society, this concept of implied consent, right? Unless I know otherwise, I'm actually protected by law. I can touch this person without their express consent. And so because of that, it's the one thing we have to opt out of, right? It's one thing we have to say no before we can ensure sort of that it doesn't happen. Otherwise, it's going to. And that's why these forms exist.
We want our patients to have a copy of this with them. Is there any place in the house that they tend to be?
Yeah, so when somebody fills out a form in such a way that it will restrict something that we would normally do, we'll talk about the details of that, but when there's something important on the form, for example, the do not resuscitate, it's like if my heart stopped, it's not an emergency, it's just the end of my life, people need to know it, right? So if somebody calls the ambulance folks and the emergency medical services show up, they need to know this or else they're going to do what they normally do. And so the place to put it is actually on the refrigerator. All of the states and counties and whatever that I'm aware of, that is what they train their emergency medical responders to do, is if there's any question, look at the refrigerator in an emergency. If they don't see something there that catches their eye, then they will do what they normally do, which is to try to resuscitate someone, which is why it's bright pink. So it sort of catches their eye and then they can take a look at it and then follow those instructions.
It seems like with a lot of our documents, there's many options and we're pretty open to having anyone be our proxy generally, or you can put whatever you want in the living will. But it seems like with the MOLST or POLST forms, there are a couple ways that when it's filled out, we kind of get a little worried, like there's some problems or it doesn't quite make sense. If you could talk about that when we have our patients fill that out of CPR, intubation.
Yeah, absolutely. So this CPR thing and the intubation thing. So CPR is the cardiopulmonary resuscitation, right? To try to restart someone's heart if it stopped beating. And then intubation is the tube, right? The tube that goes down into the lungs and it can be hooked up to a ventilator ultimately to help that person breathe. And this is a procedure, okay? So it really is a procedure like any other. And so it's gonna have risks and benefits and reasons to do it and reasons why we shouldn't do it. And also some pretty specific things about it. If my heart stops and someone's trying to restart it, ultimately, I'm unconscious. And in order to really potentially get the benefit of this procedure, I need to have a breathing tube put in almost all the time. So there are some people that would say, look, I don't want to get stuck in machines. Therefore, I don't want the breathing machine ever, but I do want you to try to restart my heart. And we can talk about what we can do about the breathing machine there. But it's really important to recognize that if we do the heart thing without the lung thing, we're much less likely to get the benefit of the procedure. And so most clinicians, most doctors would say, if you say yes to CPR, you really need to say yes to the intubation thing and the breathing machine, at least for a period of time, not forever. And we talk about that, but it really doesn't make sense to say yes to the heart and no to the lungs. So yeah, one of the things about the combinations of this heart and lung thing, the first thing to recognize is that when we do the CPR, you either do it or you don't, right? There's kind of not a way to do it a little bit. There is sort of a way to do it a little bit, if you will, with the breathing tube. One of the things I hear people say pretty frequently is, I, quote, don't want to get stuck on machines. And usually what they mean is for months on end, and then finally the end of their life comes some number of months later in the ICU. And we can actually avoid that while still saying yes to the breathing machine. And we call that a trial of intubation, right? Intubation being the tube, and a trial meaning give it a shot. And that trial doesn't have to last any particular period of time. We would generally say not more than 2 weeks for various kind of technical reasons about doing damage to the airway with the tube and that sort of thing. But one thing people can say is, I want a quote trial of intubation. So give it a try. If it's going well, great. I get better, take it out, and I go back to my life, we hope. But if it's not going well, then you can just say stop it. And that trial of intubation, when you fill out that form to say give it a try, but if it's not working, you can stop it, can actually be a little bit of a, I guess, an insurance policy for myself, if I'm the person in the bed, being intubated, to at least hope that I won't linger forever. It can also be a gift to family members, right? To sort of say that now my healthcare proxy really doesn't have to make a decision at all. They just say, well, Tom said, try it, and if it doesn't work, stop. And I'm just pointing at the paper. I'm not even making a decision, right? So there's a real benefit there for a lot of folks, that they can still potentially get that benefit of the breathing machine, but not be worried that they're going to be stuck on it.
The other thing I think we talk about a lot is, I think we come in with a lot of expectations of what code status should be for different types of patients. If you could just give a sense of the spectrum, like a young, otherwise healthy patient versus, someone near the end of their life, and what code status we kind of come in with expectations wise.
So the question we ask is, you want us to restart your heart? And it's not really the question to ask, because I can't simply restart someone's heart for sure, right? The way I like to frame it is to say, if your heart were to stop pumping blood, we can look at that in one of two ways, okay? We can consider that one of two different kind of situations. The first kind of situation is the default, which we would consider that a medical emergency, and we would try to restart that person's heart. The other way to look at it is to say, you know what, in my case, at this point in my life, if my heart stops pumping blood, it's not an emergency, it's simply the end of my life, right? Now, we don't like to think about that, though if we're fortunate enough to live long enough and not die of, again, something like a car accident, we'll actually have the opportunity to say that. And I think we can all agree that at some point in somebody's life, it makes sense to die of whatever it is, natural causes, a disease, without a whole bunch of strangers standing around me trying to get my heart going again, right? You can imagine I'm 92 and sick. Do I really need this thing? Is it really an emergency? And the answer is, for many people, probably not. On the other hand, though, you asked about, if you're young and healthy, what if somebody's 21 years old and healthy and they come to me and say, I want to be DNR? I mean, that takes me aback a little bit, right? Because there is a reasonable chance that that person could benefit if something crazy were to happen with their heart kind of out of nowhere. That's what this procedure is really for, truly. And so we'd have to have more of a conversation about that and figure out where this is coming from. And so you can imagine somewhere between 21 and healthy and 92 and sick, let's say, somewhere in that person's life as they go through the years, they'll switch from this is an emergency if my heart were to stop pumping to now it's just the end of my life. And so really the question for me as I'm sitting with a patient, as a physician, is to ask, which side of that line are you on right now, right? And it could be one or the other. And we can have a conversation about whether it seems reasonable or not and get into all the details. But I think framing it that way makes a lot more sense to say, is it an emergency or is it simply the end of my life? And that kind of, I think, helps frame it in a way that really does allow us to talk about it in a useful way.
So if I was that 92-year-old with Parkinson's disease, it's been many years, and I've been very sick for a long time, and say my heart does stop, and we do go forward with CPR and intubation, I imagine not many patients and care partners may have seen what it may become. If you could just speak a little bit to how that may go if we do CPR.
Yeah, so like we had said before, it's a procedure, right? And so there are risks and benefits. And the benefit, which I think is pretty clear, is that it works, right? And that person's heart gets restarted rather quickly, that they didn't spend a lot of time without blood flow to their brain, so there's not a lot of damage. They can go back to their life, and that would be wonderful, right? That's ultimately the goal. The downside, the ultimate, I guess, downside is it just doesn't work, right? If that's the case, then sadly that person dies. And there are some who would describe it as, well, they were sort of already dead because their heart had stopped, right? Which isn't exactly true because we can bring them back. But ultimately, if I get CPR and I die, I probably didn't suffer that much, to tell you the truth, because I was unconscious the whole time. The more difficult thing can be for those doing it or for family members who perhaps witness it or whatever it might be. Not to paint too dire a picture, but that middle ground where it kind of works, but not really is tough. That's what I think most people are trying to avoid, honestly, is it works, but not very well. I did spend a long time without enough oxygen going to my brain. And now I'm kind of stuck in a place I don't want to be. I'm awake enough to know it. I'm probably not going to get better. And then one of the more worrisome things is that I'm not dependent on machines, right? If I can breathe on my own and I can eat a little bit, right now I'm really in a tough spot. And that's one of the things people are trying to avoid. And it's a reasonable thing to say, that's a bad outcome. The good outcome is that it works very quickly and I can go back to my life. And then we have to just balance what the likelihood of those various possibilities are. And that's where it's really important to talk to the experts, right? Whether it's a neurologist or an oncologist, whomever it is that makes the most sense based on what's going on, to try to get a feel for what the likelihood of those possibilities really are for that individual person at that moment.
It seems like a hard thing to get right sometimes.
No, it really is. And I think that comes back to that question of right versus wrong decisions. And to take, again, hopefully some of the pressure off of people in the moment is to say there isn't just one right answer. One of the things that family members of my patients who have died, let's say, will sometimes express grief over, did I make the quote right decision? And I think that's the wrong question, right? I think the question is, we should be saying, did I make a reasonable decision? Did I make a decision that I think my loved one probably would have made for themselves if I was a healthcare proxy? And if the answer is yes, then we made the right decision, right? So to recognize that we don't have to hold ourselves to this impossible standard, but rather make sure we don't make the wrong decision. And then as long as we're in that realm of reasonable, then I think we're doing the best we can.
In this fourth video, we're going to talk a little bit about questions that you might want to ask your medical team or questions to discuss with family. These conversations can be so hard when you talk with your medical team or talking with family about these challenging subjects, code status, proxies. Do you have any insight or advice of how to go about these conversations? Because they can go in so many directions.
Yeah, absolutely. I think, again, having them sort of somewhat frequently, not like you have to ruminate on them every day, but at least once in a while, check in every few months, every 6 months, certainly every year. And then also as needed whenever something changes, right? If it feels like something is getting more difficult or something's just different. And then the biggest piece of advice I have is especially when you're talking to the medical team, if you don't understand something, say so, right? I think one of the biggest places where patients walk away thinking something different than what the clinician, the team thought they had said, was just because there was a little nagging doubt about, geez, maybe I don't understand that, and just didn't ask because whatever, time, feeling embarrassed, like, oh, I should know this or whatever, but just say so. Sometimes people say, oh, I didn't want to bother my doctor. And I'll tell you, the thing that I think bothers doctors most, and I'm certainly speaking for myself, is when I find out 3 months later that there was a misunderstanding and I didn't know it, right? So please, just ask if you're wondering, and it'll oftentimes make things go a little smoother. Doesn't fix all the potential hangups and problems, but even still, it's very, very helpful for us to know when we're not getting the point across like we're hoping to.
And that's so empowering, because I feel like with the history of doctors always being right, that is so different and so helpful. And along those lines, a couple phrases and terms are always there's so much going on behind it. So for example, we say, I want more time. If you could talk a little bit about that and what that really means, because it's such a loaded term.
It really is. And, we talk about time and we don't always identify and define exactly what we mean. I actually heard a physician quoted locally here some time ago, who said, actually, this person, this public person, right? Everybody kind of knows who this person is locally, actually has a pretty good prognosis. The median survival is 5 years. And I thought, oh my, that sounds awful, 5 years. But it was good in the doctor's perspective, because that doctor sees people who have very short times, and 5 years is actually pretty good. But you can imagine that human being, that person thinking, gosh, I think I have 30 years left. 5 sounds terrible, right? So time, in the goodness of the time, or what is a good time frame, really depends on where you're starting from. And so it's really worth recognizing, first off, what are we even talking about? What kind of time frame, right? If I'm thinking as the physician, if I'm thinking 3 months and my patient and or their family are thinking 3 years, we need to get closer than that to start with, at least thinking about how much time there is.
And I notice you're giving broad categories, years versus 30 versus 3. How accurate are we when we give these ideas of time?
Yeah, it really depends, and it depends a lot on the disease oftentimes, because some diseases have just much more variability than others. It depends on how far along somebody is in their disease. Oftentimes, right at the diagnosis very early on, there's a huge amount of variability going forward. As time goes on and that person progresses through the disease, it becomes more clear how much time they have often. And even still, we're surprised in both directions, both longer and shorter, really all the time. Probably the most common phrase you hear, at least I hear in the medical world, is "I don't have a crystal ball," which I think is true. And yet people, of course, know this, but sometimes they don't know it to the extent that it's true, right? It's like, it's really true. We oftentimes have to give very, very broad ranges because we just don't know.
Another term I think we say a lot, and I think patients hear a lot, and is quality, like quality of life or quality of the remaining time. And that's another loaded term, if you could just speak to, because there's just a lot behind that.
Yeah, no, absolutely. This quality thing has become accidentally, quite honestly, it's become jargon, right? Like we barely know what we mean by it sometimes. There are all these studies that about quote unquote quality of life, where they take all these answers to surveys by patients and they turn it into some number to try to figure out, and, oh man, I don't even know what it means, quite honestly, really, to an individual. Honestly, from our perspective, it helps compare one treatment to another sometimes, but not for an individual person. So what does quality mean? I try to use terms more like people's experience of life, what they're hoping to do with whatever time they might have left. And that can be anything from "I'm going to go fishing" to "I'm not going to have pain," right? I can't get out of bed, but at least I won't be in pain. And it can be anything in between there or around those ideas. And so again, it's one of those things, really, if you hear a clinician or someone in the medical world say quality, just ask, like, what is it exactly that you're thinking, right? Because if I'm thinking the best we can do is make sure this person's not suffering terribly, and my patient is thinking, well, I want to go fishing or golfing, we probably need to get closer than that, right? If we're really that far apart. And it may be that I'm wrong. Maybe they'll still be able to go fishing and golfing, right? I don't know necessarily. But at least need to bring those things out into the open where we can talk about them and make sure we're truly, as much as we possibly can, be on the same page.
And I've always been curious. We ask our patients, what is quality of life for you, and what do you want to spend your cherished remaining time on? But how much do you think that patients or us are accurate about how things are in the future? Not just about time, but just do we guess well?
Yeah, I think there are kind of two aspects of that for me. One is that sometimes there is a specific thing that somebody wants to get to, right? Whether it's a graduation or a birthday or a birth, whatever it might be. And that's really definable, right? That's going to say, if I get there, that is success. If I don't, then in some sense, I didn't succeed. What the whole plan didn't succeed. Those things I think we can be pretty clear about, like, this thing's really important to me. Though we do have to balance that. We have to be really explicit about balancing that against what it's going to sort of cost me to get there. And I don't mean money necessarily, I'd like to be part of it. But really, what's my experience going to be like getting there? Am I going to have to push through things that otherwise I might say no thank you, right? So thinking about, are there those things in the future? And if not, well, then that changes the thinking oftentimes. But I think part of your question too has to do with those less well-defined things. The sort of stereotypical example I use is somebody says, look, if I can't fill in the blank, if I can't play 18 holes of golf, kind of take me out back and get rid of me, right? And that's thinking into the future, thinking, gosh, I'm going to lose the ability to do this thing. But oftentimes when that person gets there to that point where they can't play, let's say, 18 holes of golf, they say, well, 9 holes isn't so bad. And then a little further down the road, well, golf wasn't that important because I get to spend time with my grandchildren, my wife, or fishing, whatever it might be. And so the point there, I think, is that looking forward, we think mostly about the things we're anticipating that we will lose, right? Kind of in the negative. I'm going to lose these various things. No, I can't imagine life without them. But honestly, when we get there, by and large, most people are more resilient than they think they are, because they start instead of thinking about the things they've already lost, they're more now experiencing the things they still have that they find valuable. And so I think it's important to not be overly pessimistic looking forward, thinking, well, if I can't do A, B, and C, then I don't even want to live, right? That it may be true when they get there, it's possible. But gosh, most of the time people say, yeah, A, B, and C, I thought were really important, but now that they're out of my life, look what I still have left. It's just really important to recognize that that's generally speaking the case, and there are limits, and each individual will be different, of course. But I think if we ignore that, or if we don't recognize it, then we can really kind of make decisions sometimes that just don't make sense looking back.
Right. It's like maybe forecasting, kind of like the weather. We can have a sense, but we might not be nearly as accurate as we think. I know for listeners, this could trigger a lot of thoughts to talk about with family or with clinicians. And lastly, any resources that you might recommend for others to get going if they want to talk about this.
Yeah, so there are a number of them, and again, we'll just mention a few. We don't have any particular connection to any of them, except that they're good ones. One of them is the Conversation Project. There's a quote Your Conversation Starter Guide out there. Others include Ariadne Labs, a serious illness care toolkit. Prepare for Your Care is another. 5 Wishes is another popular one that I hear a lot about. They are truly meant as conversation guides. They're not really primarily legal documents, so they don't take the place of things like healthcare proxies and living wills. And at the same time, they can be really useful to help guide people through and make sure that we're not missing any big categories of things. And honestly, they can help guide the conversation even in the clinical exam room with a doctor, right? To make sure we really are covering the things that are important. In addition to that, help us think through it on our own and talk to our families and loved ones about all these important topics.
It seems like it's kind of hard to get this stuff right. We talked about how the forecasting can be hard. We talked about how talking with this jargon can be challenging. Any kind of last advice for patients or their families?
Yeah, I guess 2 things. We said it at the beginning, I'll say it again. If you don't understand something that was said, particularly in the clinical world, just say so. Ask. Say, you know what, I'm sorry, I just didn't understand that, right? And your medical team, the clinician, whoever it is you're talking to, really should say, okay, let me try that again, right? Make sure that we really truly are as much as we can possibly be on the same page about what was actually said. So at least we're starting at the same point. And then the truly final point would just be to try to take some of the pressure off of this. This feels very high stakes, and honestly, sometimes it is. But both looking forward and also looking back, if we can say, did I make a reasonable choice for myself or a reasonable choice for my loved one if I'm their surrogate, their proxy? Did I make a reasonable choice? And was it a good choice? Which is different than saying, did I make the right choice, right? The right choice puts a lot of pressure on us, and I think is an impossible standard. It's just not a fair standard. But to say, did I do a reasonable thing? Did I engage the help that was available, right? Whether from the medical team or from other family members or whatever it might be. And at the end of the day, did I do things that were reasonable and avoid the things that were unreasonable? If the answer is yes, then that was, in what was probably a very difficult situation, that was success, right? It was the right thing. And so just to take some of that pressure off ourselves, because man, it can feel like a lot, and it is a lot. So share the burden, make sure we keep in mind what really is important, and that we're not perfect, and we're just going to do the best we can.
Dr. Huang, Dr. Carroll, thank you so much for joining us today. Welcome back.
Yes, thank you for having us.
Yes, thank you so much. So, any initial, thoughts after seeing this video again, and just mic is yours for a few moments. We do have quite a few questions from our attendees. So
wonderful. Yeah, Andrew, do you have any thoughts?
Yeah, I think it just underscores how important these conversations are. And but I really liked, Dr. Carroll, your point that it's good to have them and to take the stress off of it.
I think that's true. We do put a lot of just stress on ourselves trying to figure out just the right answer, and that's the thing I just keep coming back to, is that there are many potentially right answers, and probably some wrong ones too, but just to give ourselves a little bit of leeway in that way.
Yeah. Well, thank you both so much. So jumping into the questions, and I just want to thank our attendees for engaging. And I know it can be challenging sometimes to stare at a screen to learn these really important parts of life that we navigate, right? So I thank you all for asking these questions. A question from Babs Brookings, and she asks, sometimes it's difficult to know what's required medically. Is it necessary to carry physical copies of the state, living will, and health care proxy to avoid unnecessary suffering or delay of care? So say if you're out of state.
Yeah, that's a good question. I guess my first thought is always that these forms are almost like kind of like an insurance policy, in a sense that they move us maybe in the right direction, but they're not perfect or foolproof or whatever. If somebody doesn't know about them, they can't very well be held responsible for following them, kind of thing. So yeah, gosh, I mean, it would be a little much to carry them on our person, like in a place where somebody would notice right away. I mean, so we take a chance when we go outside, right? At the same time, though, making sure they're available. So refrigerator for the MOLST or PULSE forms, if there's something that would limit what you want done in that moment. And then really making sure that all your people have them, right? So the healthcare proxy should have their own copy of that they are your healthcare proxy. I mean, it wouldn't be a bad idea for them to also have a copy of the MOLST or PULSE form. Put the MOLST or PULSE on the refrigerator if I didn't already say that. And then make sure your primary care doctor and all the specialists that might be in different systems have access to it. And that, honestly, I think is the best we can do.
I would add that a lot of electronic medical records are increasingly connected, but many still aren't. So if like you went on vacation to, you lived on the West Coast and you went to the East Coast, some systems are connected, but many aren't. So in those cases, it's hard to predict for everyone and like have all of your documents with you wherever you go, like on a cruise, but at least where you live, it's easy enough to give those documents to your health network there. That seems, that's a pretty easy thing to do.
Thank you for those tips. Really bringing it down to the reality of what happens in these emergencies. So thank you for bringing light to that. Next question from Sharon. Sharon asks, do my healthcare decisions as documented in my healthcare proxy and living will still apply if I experience a medical emergency again while I'm outside of my state home? Does it
transferable, right? Yeah, that's a good question, right? So every state has their own, and generally, I think, don't quote me, I'm not a lawyer, but I think they're like the spirit is usually honored, once we have a chance to make sure that it was really appropriately filled out, or it was really, kind of legal where it was supposed to be legal. We certainly have had people from out of state in New York here who are from elsewhere, and yeah, I mean, we honor their healthcare proxy unless there's some reason not to. But if I don't know if there's specific law around that. Andrew, maybe you know more than I do about that.
No, yeah, that's what I was thinking too.
Great. Thank you. So Sharon also asks, she highlights, Parkinson's disease often brings on apathy. And her experience, she's kind of sharing that less decision making on behalf of her spouse living with Parkinson's disease. And her person with Parkinson's, whatever you decide is fine with me. I trust your decisions. Do you have any advice or tips that can provide for responding to a person with Parkinson's who just doesn't want to make these decisions and is really giving that full burden of end of life decisions to their partner?
Yeah, I have a couple thoughts. I think for one, it would be great to ask I think it's the patient, the husband of Sharon, maybe, to ask more about it and try to understand more about care preferences. I think a lot of times, a lot of care partners feel a lot of weight of the decision, especially if they're, your loved one says, whatever you think is best, it's just so broad, hard to interpret if you're in the ICU 3 weeks into an admission and you're just thinking about whether to do a breathing tube, a permanent breathing tube, or a feeding tube, and what that all means. So, I think we commonly say to our families that we really want to be the voice for our patient and not that the care partner, husband, wife, is deciding for the patient. So as much as possible, understanding more, asking more about that, having more conversations to understand any preferences are going to be really helpful for those future decisions. And you can't predict them all, but I think it's worth having a little more than whatever you think is best. I trust you.
Yeah, no, I agree with that. One thing that we might do if we're in the position as the care partner here with this person with Parkinson's is just to say, okay, husband, here's how I would make the decision. Here's how I would think through it. Does that make sense to you? If he's able to say yes, then I mean, we have a little bit more, I think, comfort saying, okay, at least we agreed on that. If he's still not able to, I mean, maybe he's in a place in his disease where he just can't. And now we do the best we can. And I would say don't do it alone even still. Talk to the doctor, to family members that you trust, friends that you trust, whatever. Because I'll say it now and I'll probably say it again, don't do it alone, right? I mean, really reach out to people because they can at least say, you know what, if you're crazy, we'll be crazy together, right? I mean, because otherwise we feel like we're just out on a limb, and we shouldn't feel that way almost ever, really. So I hope that's something we can take forward too.
All right, so what I'm hearing is keep asking and perhaps propose a scenario that, might the person with Parkinson's be able to say, yes, that sounds like it works for me. Thank you. So another question we got is how can we effectively communicate our needs to healthcare professionals to receive support instead of waiting to the end of life? So we're having this conversation today, right, to promote us making these decisions now. How do we communicate with our healthcare professionals about the end of life wishes that we'll have?
Yeah, I'd say, bringing it up is great, especially with your primary care physician. And I think most of us clinicians, we want to talk about it too. So there may not always be a designated time, but I think bringing it up is always fair game. And I think especially if it's just, I had this conversation with my family member about, the future, or I listened to this webinar from the Parkinson's Foundation. Great starters.
Thank you, Dr. Huang. We got a question. What if I checked no feeding tubes on the living will and the situation is such that I would benefit from an IVS or a feeding tube? Could my health proxy override that directive? Would it be better to not check the boxes but leave the decision to the proxy?
Yeah, no, that's a great question. So the short answer, and then I'll give you the slightly medium long answer, is the answer really should be don't check the box unless we're really pretty sure, right? So as I get sicker and sicker and sicker, it becomes more obvious and there'll be fewer surprises probably, right? Because here's the thing, if I check something off on a form and then it's a document, that is an expression of my wish in that regard. And our healthcare proxy's job is to make my wishes happen. So now the scenario that you brought up, which is a good one, it really does happen, is now we have my wishes over here, and now we have the healthcare proxy saying something different. So in order to, it is possible to change that, to override that form, if you will, as the healthcare proxy for somebody who doesn't have the capacity anymore to make that decision. But for my money anyway, what we have to do, that healthcare proxy has to do, is show that the situation is different in a way that the patient themselves did not anticipate. Right? So it's like, there's something different, my wife, she didn't see this thing coming, there's some new information, but it's a high bar and it's hard to do oftentimes. I've run into physicians who say that's not possible to change it. And I say, well, that's can't be true. Otherwise I would never fill out one of these forms, right? I mean, I'm not going to completely tie the hands of the people who know me and love me and are doing the best they can for me. But at the same time, it should be hard to change because I've made a very specific and strong statement in writing that should be hard to change. And so it is difficult. So I say, be careful. And if ever you're in that situation, ask for help, right? Again, ask for help. There's an ethics committee at every single hospital. And if you're feeling ever like the clinical team is sort of saying, well, you can't do this thing, you're like, but I think I should be able to, get somebody to help sort it out. So don't feel like you're alone or that it's a fight that you have to somehow, they're probably doing what they think is best for your loved one too. And I think the important thing would be just to get everybody on the same page and get that extra help, whether it's from ethics or somebody else, is a useful place. And I say that not making up, because it really has happened and it's a tough place to be. But that's one of the risks of the forms. And there are also huge benefits of the forms too. So we just have to, again, balance those things in any time we go to fill them out.
Thank you for that. Alethea asks us, if you have a person with early onset dementia, does CPR or intubation create additional damage to the person?
Yeah, I can give a stab, and not necessarily. I think in as much as a patient with early onset dementia and has a lower functional status than another patient, certainly. But I don't think there's anything special about having an early onset dementia that makes the intubation more damaging or more hard on the body than an older patient with dementia. Yeah.
Yeah, no, I agree. And I think it's really a question of, are my heart and lungs healthy enough to come back from this? Right. And to some extent, I mean, does my brain have reserve, right? So we know that like a younger person can probably spend longer without a heartbeat and come back better than somebody who's dramatically older. But everybody will be different on that spectrum, right? It's just on average, as we get older, we just have less reserve in almost every way, including how long we can spend, without enough blood going to our brain. So yeah, this is where these questions get really specific and tough. And again, there's not always a right answer, and it's worth talking over time with somebody you trust in the clinical world too.
I think we have time for one more question. So I'm going to give you all a pretty in-depth one from our guest Alethea again. She asks, is there a particular legal form for assisting with bringing about an intentional end of life? And there's lots of sub-questions under there. What are some key considerations when engaging in advanced care planning? Specific challenges to consider? Any adjustments needed as the disease progresses? Specific legal documents that must be completed? And again, thinking about an intentional end of life.
Yeah, that's a big question these days, right? And it'll be different from state to state in the US, and certainly from country to country around the world as well. And the label for this, I guess, is request to hasten death, right, in the medical world. And then it goes all sorts of different labels, right? So physician-assisted suicide, physician-assisted death, medical aid in dying. And there's a lot of controversy around this. I guess what I'd say is anytime somebody feels like they want out, right? If somebody's thinking like, I'd be better off dead and that's what I want, it's worth talking to your doctor. What we find out is that most people don't really want to die. It's an expression of just backed into a corner. I got nowhere else to go. And oftentimes we really can fix the problem. Often, when we can't, then it goes into the whole ethics of this thing and what state are you in, and things that are hard to generalize about. But I think if that's on your mind, or just say it, because people suffer a lot feeling guilty about having those thoughts or whatever. It's just say it and bring it up, and somebody out there will be able to talk to you about it. It's a hard thing.
Yeah, and I think different doctors will have different comfort with how much to go down that path, and especially in different states where it's legal or not legal. In a lot of palliative care settings, there are patients who have uncontrolled symptoms at end of life, to where using palliative sedation it occurs, and we know it may bring about a faster death. But those are kind of specific, unique situations. I think in terms of preparing for it, it's like Dr. Carroll said, I think the more of a thorough understanding of why, and in discussions with clinicians, I think that's where you can get a much better understanding. But the states that do allow it, it really is a prescription that the patient has to be able to take on their own. And many patients at end of life are not in a position to be able to do that. So even though it is an option in some states and in some countries, many patients with their journey are not able to actually take the tablets, and are not able to have like someone else give it to them. So kind of complex, and some more limitations and options than you might think.
And how can family members or caregivers, loved ones, actively participate in advanced care planning? So ending on a note of support, and we keep coming through this thread of asking for help, asking for clarification. How can our loved ones who are in our circle, in our networks, support this advanced care planning for us?
think just be there, right? I mean, even if it's not, maybe not physically in the room, but just be there in a sense. Like just talk about like, what are the important things? Make sure we're on the same page. And when a doctor says, oh, talk to your family members about your wishes, be as specific as makes sense, but don't be afraid to be general too, especially if it's early on. Because being too specific, you have these crazy conversations at Thanksgiving or something, and sometimes you don't like, what do I do with that, right? That's weird. But really, just to say, yeah, this thing's coming. Whole bunch of things could happen. Let's keep talking as we go, and then we do the best we can.
Dr. Huang, any final words as we come to a close of our webinar?
I don't think I could have put it better.
Well, thank you, Dr. Carroll, Dr. Huang, and for all of you for joining us today.
Thank you. It was very nice to be here. I appreciate it.
Thank you.
Please know that a follow-up email will be sent with a survey. Tell us what you thought about today's program. It helps us fuel our future programs around the end-of-life process, palliative care, and so much more beyond the vast, vast topics of living with, impacted by, and working towards finding a cure with Parkinson's disease. You'll also receive a link to today's presentation and additional resources. If you had a question today, I'm so sorry we couldn't get to all of them. If it was unanswered, please reach out to our helpline by calling 1-800-4PD-INFO or emailing helpline@parkinson.org. You can use that same contact information to order our free resources such as educational books, our hospital safety kit, and so much more. We thank you for joining us today, and I hope to see you again soon. Be well.